Now it is with great honor to be able to introduce Dr. Fiza Remzi, who's a colorectal surgeon at the New York Medical Center. He's an expert in the surgical management of inflammatory bowel disease. Dr. Remzi is an international surgical leader in pouch surgery and complex abdominal pelvic reoperative surgery and sphincter saving surgery for rectal cancer, applying minimally invasive techniques. Dr. Remzi is the director of the Inflammatory Bowel Disease Center at NYU Medical Center and is only one of the few colorectal surgeons in the world that specializes in caring for patients with problems of J-pouch. He has cared for patients for over 20 years. He's very well published. Dr. Remzi is a member of the American Surgical Association and one of the only handful of surgeons that is also part of a worldwide renowned organization and a member of this called the International Organization for Study of Inflammatory Bowel Disease. Please help me give a warm welcome to Dr. Remzi. And Dr. Remzi, thank you for joining us at IBD Horizons.
Good morning. Thank you so much for having me. And again, it's a great privilege being here and so humbled to be between this type of incredibly bright people. And also, I'm sorry about the color of the slides, a little bit different, that I was supposed to be here early yesterday morning, but one of my patients got a little bit sick, so I couldn't mentally leave her, and I took the later slide, and my sincere apologies for that confusion. But again, thank you so much for the organizing committee for this kind invitation, and specifically Paul for your organization, your help. That was wonderful. So I'm the con guy, okay? And this is nothing to disclose as a conflict of interest. We have the privilege of taking care of patients with the inflammatory bowel disease, why being on perioperative medications matters. Surgical septic complications, infection, and this is a long course humbling disease, and it can devastate the patient's life for a long time. An art of colorectal surgery is being prepared for the unexpected. You need to be humble. You need to ask questions. If you don't know something, refer to the patient who can do the things better than you are, and be direct with the patient, because patients can forgive complication, but patients cannot forgive ignorance and being mucked around, not a clear answer what is going on after the complication happens. And in colorectal surgery, when you have the humility and modesty managing these patients from the surgical aspect, there are so many things can go wrong. And I just want to show you what these things I'm talking about and why what Dr. Hanauer said is so true, specific, and we need to act like we're not agreeing with pros and cons, but it's so true for these patients what the things can go wrong, because this is not a simple procedure. And honestly, God, if I cannot wait the day that we don't be needed as a surgeons in the management of these patients, but unfortunately that's not the case. But until that happens, I think our personal agenda and my passion is having these patients to be managed in a centralized fashion, like in Canada and Europe, rather than anybody can touch it surgically, because a lot of price is paid by these patients because of this lack of centralization in our country. So this is the gold standard procedure for ulcerative colitis, the total proctocolectomy and J-pouch procedure. So we're removing the whole colon and the rectum, creating a J-pouch from out of a small bowel, hooking up to the patient's anus. And a lot of things can go wrong. This is really challenging the nature. The God creation is being challenged here. During this process, you remove the rectum all the way, and that's the things that we're talking about. One stage being all at once done. 2 stage means you do it all at once with an ileostomy, close the ileostomy in the 2nd stage. And the 3 stages, do the initial colectomy, then do the removal of the rectum with an ileostomy, and close the ileostomy. So when you do these procedures, and this is the Achilles tendon of this procedure, that when you do this hookup, the things can go wrong. You're making this J pouch, created this with this firing of the guns, and you make this anastomosis and making sure no leak. A little leak can be very, very devastating. You check leak. If there is no leak, then you close the ileostomy 3 months' time. So this is the simulation of that. These suture lines are incredibly, tedious, and the healing impact. So for these patients, as what was articulated to be, optimize their situation preoperatively, absolutely is critical. Or, if it cannot be optimized, not taking the unnecessary chance on their behalf by changing the type of procedure, which we're going to talk at the end of this presentation, is incredibly critical. But not to market. I can do this in one stage. You don't need an ileostomy. Or you don't need an ileostomy. These drugs don't have any side effects. We can give you one after another, and then the patient comes on a death row and see the surgeon as a Dr. Evil standing with a knife in the corner. Is not helpful for anybody. They are the one who pays the price. And this is the creation of the J pouch. Again, one little hole from that are the ones that happens. And this is something that I blame my surgical colleagues a lot. They're saying the fact that the surgical things goes wrong, and suddenly the patient is referred back to gastroenterologist. You know what? This is not surgery. This is Crohn's right now. Suddenly the patient's diagnosed as diseased, and then the gastroenterology colleagues started treating these patients with a biologics back again, presumed diagnosis of Crohn's disease. Why? Because of this lack of communication, integrity, and understanding between our gastroenterology colleagues, surgeons, and the patients. Lack of visibility of acting as a unit. So Crohn's disease, as what Professor Hanauer said, despite, this is a very old study, our existence has been delayed initially, as what was said, but has not been eliminated. And I told my wife, I cannot wait the day that I don't need to operate on patients with Crohn's disease. And I also I don't want to go back to the earlier debate. I think the thing over here is not the treatment, is the prevention. We got to focus on the microbiome so the patients don't get the disease, because after they get the disease, like the diabetes and everything, it's too little, too late. So the indications for this surgery is number one, medical therapy. And again, in these surgeries, a lot of things can go wrong. You're putting the small bowel back to the colon. And patient with Crohn's disease with the structuroplasties or resections, you have so much suture lines that you'll be dealing with that may be potential for a leak and a potential catastrophe. And these are the patients actually needs the biologics on the perioperative era the most. So for these patients, I just tell them, look, I'd rather have you to be upset to me for 3 months and give you a temporary ileostomy, get the biologics and everything safely, rather than you dealing with the consequences of a major leak from any type of these structuroplasties that may devastate your life for a long time. Then you'll be upset to us for a year or two. So when it comes to the point of my discussion, of do I stop the biologics perioperatively? The answer is yes. But is it biologics the only things to blame for the potential postoperative complications? The answer is no. I think we wasted so much time of this with years, biologics to blame or not the biologics to blame. I think the fact is if we can work together as a unit, have the patients to refer to us on a timely, it's very critical. So why does it matter, and why the data is so controversial? And I'm going to talk about the con part of it, that why the biologics can be detrimental about the things. So it impacts healing. And when we look at the cohorts, the studies are so all over the place. So you cannot get or find a study that is really compares to apples usage of the biologics preoperatively, without stopping continuously, and not to be able to change the disease or the surgical course. That is really the key part of the frustration from the surgeon aspect. It is so critical for the gastroenterologist when the patient comes to a surgeon, you know what? Let's try the biologics. Let's try to avoid the surgery. That's all good. In no means in 21st century, some surgeon is going to say the fact that you should be sending a patient to me without trying the biologics. I completely agree. but not one after another, not after another, third, fourth, and the patient comes really sick, then blame the surgery, not the biologics. Or also unfairly blame the biologics, where it's actually not maybe the better management of the patient to be sent to the surgeon timely. So what the literature tells, there is lack of standard definitions relating to dose and duration, compares the apples to apples between the studies. Timing of cessation when the medication for the surgery is all over the place in these studies. Detailed information about the effect of other immunomodulators or other medications, including the steroids, can be a concern, not to allow us to make apples-to-apples comparison. So this is a credible group from Cedars-Sinai. They initially looked at the fact that the biologic infliximab doesn't make a difference. Earlier studies, they said the fact that it didn't. But it's a small cohort. But one of the things that's so important here, a good amount of patients get a subtotal colectomy. I mean, getting a subtotal colectomy and say the fact that don't have a complication is like having your car staying in a parking lot and say the fact that I don't get in an accident. It doesn't work that way. Or having a plane and a tarmac and the plane is not flying and we don't get in the accident. It scares me when I talk about flying this afternoon. But that's the apples comparison is very important. And then, they compare the subtotal colectomy results, and they say the fact that the cyclosporins is the blame, not the infliximab. But to me, I think the patient has been on so much medication is to blame, and potentially was sent to the patient, the surgery late. That caused the problems rather than each one of them. I think this cohesiveness before the surgery is very important. And this was a critical article really brought this to attention from the Mayo Group. Even the fact that the senior surgeon is a dear friend of mine, John Pemberton, Bill Sanborn is on the case and everything. And what they found the fact that the patients who undergo two-stage pouch, which means doing the J pouch, everything all at once, with the ileostomy, not doing the initial colectomy, has a significant impact on the results. But be careful, again, this is really an unfair situation of the biologics. When you look at the things, patients on the biologics were much higher dose of a high-dose steroids. There were also a significant amount of difference they were using, the 6-MP type of products. But their results showed the fact that, and they said the fact that you guys got to be careful. Yes. As they say. Just to make sure that Paul sent me a thing, because of the fact that I was a little bit late coming here, the slides in the system is the same. The only thing that's different, some of the graphics and the videos I showed, but what you have the slides are exactly the core slides that I sent earlier to Paul to be discussed. When you look at the multivariate logistic regression showed overall complications were 2.7 times more common in patients with infliximab. And, I'm very liberal of stopping the biologics before the surgery because I want to get one thing out of the picture that may really impact this patient, but I also change the type of surgery what needs to be done. This is our study because of the Mayo Clinic study. Why don't we look at it too when I was at the Cleveland Clinic. And what we found the fact that, and being critical of the fact that we got everybody who used biologics beforehand, even greater than 16 weeks. And it was legitimately people criticized very harshly, how can you compare somebody who used 16 weeks before the surgery as a negative things? Because those patients can be also criticized. Patients were sent to us late. But when we look at the subgroup analysis, it didn't matter. I think, again, sending the patient potentially not timely to surgery is the problem. When we look at these patients, 523 patients, 85 patients had infliximab at that time. Again, this is an earlier year, so the usage of infliximab in the setting of UC was not common. So for 2 stages, which means doing the J pouch and total proctocolectomy with ileostomy, we found the fact that how are we going to compare apples to apples? So we compared the patients who did not have a biologics versus did get a biologics. What we found the fact that number one thing that impacted these results were sepsis, leak, and early postoperative complications were all related to, maybe related to infliximab. Pouchitis also impacted because, again, why? Patients get a leak, they get an abscess, surgeons say, oh, this pouchitis right now. Most of the patients who complain about pouchitis, you need to question about their surgical history, what went wrong at the initial surgery that they may be suffering pouchitis, which is actually not a pouchitis. It is actually secondary to their surgical complication. I bet that's the reason these patients have a higher risk of pouchitis, but actually a surgical complication and sequelae carry on later on the years. So what we found here is the infliximab brought a dramatic increase in the sepsis, leak, early complication, and pouchitis compared to the other factors. Again, I'm being critiqued to my paper, our paper as a group. In this setting, it's again very confounding factors was emphasized by Dr. Hanover plays a role. So let's talk about also the 3-stage. So we made a big deal out of this thing. Well, if you get on an infliximab, you may get a 3-stage procedure. I think that thought process is gone. It is not a big deal because the patients are going to require biologics before they're sent to surgery, which is fine because it's unfair for the patient not to try the biologics before sending to a major surgery. But if they are referred for a surgery under the biologics, I think patient needs to know the fact that they're going to have a much likelihood chance of an initial colectomy and have a 3-stage J-pouch procedure rather than a 2-stage J-pouch procedure. I think that's understood. That's quite all right. And that's the reason they're still a bit behind right now. We used to say, well, if you get one, you do it. I mean, it's also unfair to recommend somebody a J-pouch procedure without trying the biologics. And this was the indicative of that slide. Now, this is the Bimmelman group from the Netherlands. Their definition of 1 and 2 stage is different than ours. They talk about 1 stage as a total proctocolectomy J-pouch with ileostomy or without ileostomy, which is different than our definition. And their definition of 2 stages, initial colectomy, no J-pouch, followed by a J-pouch later with or without ileostomy. And they also found the fact that despite statistically different, but this is their conclusion I'm just talking about, that patients who had a 1st stage, they had a higher increase of pelvic sepsis, 5/21 versus 0/1, because they said the numbers were low. And because of that, the Dutch group also recommends when patients are on biologics, be liberal about doing the initial colectomy rather than having the patient to undergo to a J-pouch procedure with an ileostomy or with no stoma. Now later on, because of the critique and everything of our original study by Moore, I said, why don't we look at it now, several years later, because our surgical approach to these patients changed. Which means rather than trying to do all at once with the 2-stage procedure and a given ileostomy, closed ileostomy in 3 months, we became pretty liberal to do an initial colectomy, followed by the J-pouch and proctectomy in 4 to 6 months, and do ileostomy closure 3 months. Like rather than 3 months stoma, patient may have 7 to 9 months stoma. What we found the fact that the biologic side effect continued to blame in our mind, but a lot of confounding factors. What helped the patient out, this is the Kaplan-Meier, that if the patient get a 2-stage when they were on biologic less than 12 weeks before the procedure, we put the adalimumab at 2, that they had a higher risk of septic complications. But this septic complication, what matters is able to be mitigated, which means minimized to barely anything by staging the procedure with the initial colectomy. I think that's very important for the patient to understand that the surgical treatment of their complicated ulcerative colitis is not a 100-meter sprint. They suffered along for years. It's a little bit a marathon they need to understand. It's so critical to have the gastroenterologist, to have the surgeons back, that don't pick up a fight between 1 or 2 stage and everything. Get what is the best thing that's done that's going to impact. I cannot wait the day that I'm not doing reoperative J-pouch surgery because of this lack of cohesiveness and lack of our communication to our patients and lack of synergy that has a room for an improvement as our gastroenterology colleagues and surgeon. At the end of the day, I mean, they suffer because of a surgical complication that could have been avoided in a better way because of us. So this is also another study. What it shows the fact that 5 studies that preoperative biologic use increased the short-term total morbidity in 4 cases and everything. So the data is out there that the biologics impacts healings that the surgery may not result in a good outcome. I think changing the surgical strategy is the solution rather than make an argument that you should not be using biologics beforehand. So, but despite that, I still stop the biologics in patients who are undergoing for surgery for ulcerative colitis 1 month before, and then do the colectomy, get them off and everything. I try to teach to my fellows and residents, any doubt, don't hesitate to stage your procedure. Now, in the next 2 minutes, I just want to talk to you about the Crohn's disease. This is the study. Again, we pushed it and said, let's look at this biologic era. And when you look at this, there are 3 groups. One, patients in the biologics era that didn't use biologics. This was an earlier phase of the biologics. A group that used biologics. And the other group was the pre-infliximab treatment. What did these patients do? When you look at these type of the disease, so it's an apples-to-apples comparison. Also, some of the medications were different because of the timeliness of using it. But overall, that's the comparison shows. So A is comparing the no-infliximab to infliximab. B is comparing pre-infliximab to infliximab. What we showed the fact that the patients who were on infliximab had a higher rate of complications, at least in our hands. And some of the things that was concerning is patients who were on biologics and not biologic at the biological era, they had an anastomotic leak rate that is the same. But the patients who were treated at the pre-infliximab era compared to the infliximab era had a much lesser anastomotic complication. Why? Patients coming to surgery later than usual. And that's the reason that something needs to be understood in that regard. So that is actually a good proof of that, showing this difference. So when we look at the results in the multiple logistic regression model, I think it's important to see that it impacted the outcome, these drugs. As what Dr. Hanauer said, what you're doing is right, what you're doing is right, continue to do that. What we found in these patients, and we showed it in a very bad way to the medical society, a different way. We could have done it better. We said that if these patients come, that they may be getting a more stoma is a negative. But it's sad the patient may need a stoma, but that's okay, as long as they tried the proper biologic before the surgery, got the stoma for 3 months, and they understand the fact that that's for their safety. So we were able to start the medications on a timely fashion for their treatment that is required for the rest of their life. But the fact is, these patients required more stoma for the right reasons. They were sicker. Whether it's absolutely related to biologics or not is open to question. And this is the last study, impact of postoperative immobilization and postoperative outcomes. Can be seen here out of the 21 studies. A significant amount of them show the fact that infection complications were significantly higher in the anti-TNF group, including in some of the studies, wound infection and septic shock in some of the groups. So this is the results of that study. So what's the timely surgery? I still don't have a clear answer. Communication with the gastroenterologist is very important. Timely resection can achieve rapid response remission, reduce time to return to daily activities. Surgery after failure to respond medical treatment might be required to treat complications, and the overall result of the morbidity and quality of life can be worse if the early surgery had been performed. So the late surgery might need more radical than early surgery, can increase the complications. And this is the thing, the solution. The solution is indication. It needs to be changed. So when the patient comes for a J-pouch, I like to stage them for these reasons. And it's very important not to do the J-pouch when the patients are on sick, or if the patient are on biologics and everything. And this is very critical, especially patients with a severe jejunal ileitis, that the patient is going to need our gastroenterologist's help pretty soon after surgery, despite I start the biologics, but I am liberal with the stoma so they can be started the biologics to treat their severe jejunal ileitis to help them not to get into trouble. So I'm going to wrap it up here. This was a surgical complication of a patient that the pouch didn't go well. This is after 6 years of being treated as a Crohn's disease, a major infection. That mushroom catheter there is draining the pus and abscess, and we have to excise that crot and infection. Where this is at this stage, this is the top of the bottom of the patient foot. This is the head. That is the right on the patient. It's me, and that is a chronic infection. We're trying to excise to be able to give her another shot. I mean, she was devastated, couldn't accept to live with a permanent ileostomy. And I genuinely do believe there is a room for an improvement as surgeons and gastroenterologists, that we can strategize and communicate the indication of a stoma and the stages of the procedure better. And you need to excise this infected crot to be able to give this patient a better chance of that infection will not impact that patient, the new ileal pouch anal anastomosis. My last slide is pretty similar to Dr. Hanover's. Early discussion of surgical options is critical. Define the goals, medical and biological is important, and clearly define the criteria for referral to surgery, better understanding of contributing factors. Once again, I'm very much grateful and humbled to be here, giving me an opportunity to talk. Thank you so much.